is a meeting with some representatives from the Child Abuse and Neglect Advisory Committee of the FACT Board, the Family and Children's Trust Fund, and it's a panel discussion on about child-on-child sexual assault. A couple of housekeeping issues. We have a lot to do today and a little less than 90 minutes to do it. We have a great panel of experts to hear from today. So it's a complex topic and we want to make sure that we hear from the panelists. So what the format for today is that we're asking you to mute yourself and to direct questions or comments that you have through the chat feature. And then Nicole is going to monitor and raise questions from the chat as they're appropriate to our discussion. Okay, so if you please mute yourself during the discussion. Is Janine on the call? I don't see she's here yet, but okay. So again, tell you a little bit about the CAN Advisory Committee, again, subgroup of the FACT Board, established in 2012 with membership from state and local stakeholders interested in child abuse and neglect and working in that area. How this group got into FACT was through a government reorganization under Governor McDonnell, where he combined the Governor's Advisory Board on child abuse and neglect with the FACT. And so Nicole had a little bit more work to do and added that to the agenda and the work of the FACT group. So what we do on the CAN group is we advise the FACT board regarding prevention and treatment of child abuse. We review policies and practices of local and state departments of social services. And in fact, we act as a citizen review panel for that group. We advise, we make recommendations for changes for policy and procedure as appropriate, and we advocate for effective child protection. So that's kind of just a very brief introduction. We have been talking on the CAN committee with, and again, that's the Child Abuse and Neglect Committee. We have started to discuss the issue of child-on-child sexual assault in Virginia. And we recognize right away how complex the issue is. It ranges from problematic sexual behavior, typically in pre-adolescence and adolescence, to actual sexual harassment and sexual assault toward other adolescents or younger children in a variety of contexts, in schools, homes, athletic organizations, institutional settings, these sorts of things. We also know that the jurisdictional issues right now are really, they're not complete. So CPS handles cases where the alleged abuser was a caretaker for the abused child, and that's the limit of their jurisdiction in these cases. And then law enforcement and prosecutors would have jurisdiction over other kinds of cases. But that's not whole or total, and we really need to think about how to address that. We know and we are concerned about whether or not treatment options are effective for this behavior, all the way from sexual assault to problematic sexual behavior. And we're not sure that we actually have the counseling and therapeutic capacity in the state to deal with the issue. And then finally, we talked about how there's a lack of understanding in the general public with regard to families, for how to address these issues with victims and perpetrators. The general public has a problem, kind of issues with sexual assault in general, okay? So it's this kind of set of problems that really led us to set up this panel today, okay? So what we want to do is we want to use our panelists to kind of learn about what are the challenges associated with these cases from where you sit in the world, what are some successful strategies you've identified to work with these cases, what kinds of opportunities are there for state level intervention or change, and how these cases are handled. And so that's the direction that we want. That's the ideas that we want to process today in this little panel discussion. We also want to make sure that you all know this is just the beginning. We recognize this is to me, like, I think about it, the analogy of the elephant. There's lots of hands on at different areas, and so we are really trying to paint a picture of what's available, what are the gaps, what resources do we have, what do we need, and how do we help families and children with these issues. So at the end of the presentation, we'll end up talking about some next steps that we are considering, and next steps might include bringing other people, having a forum like this again, and bringing in other perspectives as the need for those are identified. Okay, so let me introduce our panelists. And as Nicole let us know, Nancy Oglesby won't be able to be with us today, but we have Sergeant Sandy Ingram from the Franklin County Police Department with us. And thank you, Sergeant Ingram, for stepping in. We have Art Mayer, who is the Clinical Treatment Program Supervisor with the Virginia Department of Juvenile Justice. We have Quen Yang, who is the Student Services Specialist in the Office of Student Services in the Virginia Department of Education. We have Janet Dinkins Davidson, who is the Executive Director of the Children's Advocacy Centers for Virginia. Shannon Hartung is with the Virginia Department of Social Services. She's the Program Manager for Child Protective Services in the Division of Family Health Services over there. And then finally, Lisa Wright. She is the Richmond Child Advocacy Center Coordinator, Trauma-Focused Treatment Services Coordinator, and Greater Richmond Trauma-Informed Community Network Coordinator with the Richmond SCAN, which is Stop Child Abuse Now, okay? So thank you all for participating today. So as Nicole set this up, basically she asked that each of the panelists tell us a little bit about their work, just 2 or 3 minutes, just introduce their work around this issue and to provide some relevant information specific to their agency or program relative to child-on-child sexual assault. So that's kind of where we're going to start. And again, as you have questions, please do put them in the chat, and then Nicole will introduce them as they seem relevant to our discussion. Okay. So let's go ahead and start with, can I start with you, Sergeant Ingram?
Sure. Would you prefer me to type everything, or you want me to be verbal at this point?
Verbal, please. Yeah.
Okay. Well, I'm Sandra Ingram. I'm Sergeant with Franklin County Sheriff's Office. I've been with the agency for 25 years and mainly worked child abuse and sex crimes for the last 20. I work daily with social services. I actually have interviewed 2 children this morning for child on child. So that's that it appears to be about 25% of our cases at this point from Department of Social Services is the child on child aspect. So I'm interested in trying to find new ideas or other opportunities for these families that may help the children move forward.
Okay. How about Art? Is Art here? Yes, here you are, Art.
Hi, good morning, and thanks for having me. So I'm going to try and condense everything I can into a couple of minutes. So I've been with the department about 28 years, and primarily what I do is I oversee clinical programs. The sex offender treatment program is probably the largest program that I oversee. And just to kind of give you a snapshot of what that is, we began treating youth that were committed to the department with sex offender issues basically in the early 90s. Initially, there wasn't enough. We opened up a program at Hanover Juvenile Correctional Center that we didn't even have enough kids to put in there. We had to go around each facility And then once the judges found out that we had the program, we began to see more commitments. And so since the early 90s, we went from having several institutions to now we just have we're down to one, Bon Air. So we kind of hit this bell curve where we had as many as 200 youth at the various facilities in various forms of treatment. And now we have about 50 active across Bon Air, some residential facilities that we contract with, and some of the CPPs, which is a community placement program at various detention centers. So when youth are basically adjudicated of any kind of a sexual behavior, usually what happens is the community tries to intervene first. And by the time we get them, they've usually exhausted what they have in the community. And so they come in and they're assessed at the Central Processing Center, known as CAP. They're evaluated, they get psychological testing, personality testing, and they get a psychosexual evaluation, and we look at risk. So the program is based on risks, needs, responsivity. It's a cognitive behavioral program. And so basically, if you're committed to the department and you have sexual offender treatment needs, you're generally going to end up in one of three programs. So we have three levels. Level one is the most intensive level. About 80% of the kids that get committed to the department with a sexual offense or some kind of inappropriate sexual behavior are going to end up in level one. Level one, we have 3 units that basically we call them self-contained units, where everybody who resides in those units has a sexual offense of some cause or nature, or they have some kind of history of inappropriate sexual behavior. So level one programming focuses on things like sexual preoccupation, deviant arousal. You usually have a pattern of offending. Your offenses might be violent. They might be very intricate. You might have cognitive distortions. That's kind of an oversimplified version of who the population might be who would end up in level one. Treatment usually consists of group therapy a couple times a week, individual therapy, family therapy, psych ed groups, that kind of a thing. Length of stay in our program is generally anywhere from 1 year to 2 years, depending on how well you do. It's cognitive behavioral, trauma focused, trauma centered. We have a level 2 program that focuses on kids that don't necessarily have the same level of deviance. These are kids that primarily have a simple history of offending. Maybe they were more opportunistic and less predatory. Maybe they had one victim that was someone that was close to them, or it wasn't violent, where there isn't an ingrained pattern of offending, where it was, it might have been more behavior having to do with conduct disorder. And so that program is also housed in the same units as our level one, but they're in a different track. And we focus a lot more on social skills and healthy relationships, that kind of a thing. And I will say this, in both tracks, or whether you're in 1 or 2, we treat the whole person. So the program is very holistic. And so we're looking at all kinds of things. We're looking at aggression management, we're looking at skills building. We're looking to make them better people overall, and not just attack, what they did inappropriately in terms of sexual behavior. We look to improve them all over the place. And then the level 3 program are basically, they don't get housed in a special unit. They can be housed anywhere. And these are kids that generally have, maybe they have a history of just exposing, or something that would be considered hands-off or nuisance offense that wouldn't necessarily, we don't want to put them in a self-contained unit with other kids that have a lot more ingrained behavior. So I just gave you the down and dirty. That was a pretty quick overall snapshot. I'll be happy to answer questions as we go along. Thank you.
Thank you so much. Corinne?
Sure, thank you so much. My name is Gwen Young, and I am a student services specialist with VDOE. And from VDOE's perspective, we look at this topic from 2 perspectives. One is prevention or education with students as well as with staff, and then the intervention piece of it. And from a prevention aspect, the topic is really a range of issues, right? So anything from personal boundaries and privacy to bullying and harassment, which would include sexual harassment, to dating violence, to human trafficking. So really covers a whole gamut of areas that relates to this. And so, for example, in terms of prevention, we have learning standards for family life education, starting from 4th grade through 12th grade, that relates to recognition, awareness, and prevention of these various topics. So dating violence, which includes date rapes, sexual abuse, to sexual harassment, to human trafficking. So all of these topics are covered on an annual basis for, like I said, starting from 4th grade. And then for our staff, they are required. There's a lot of different training that's required, but the main one would be related to recognizing and reporting child abuse and neglect, which that would include now the topic of human trafficking, being able to report that. We also have high-level training for school divisions related to trauma-sensitive schools, bullying, anti-bullying, and harassment in terms of how to address that. So, so our staff are trained that way. And then from an intervention perspective, we do provide support services, social emotional supports to students, at least on a short-term basis. And then if there are more in-depth services that are needed, our staff will typically make referrals out to the community for services outside of the school. And from a student conduct perspective, these incidents are tracked. So we do have data reporting relating to discipline, crime, and violence. And the incidents, schools that report on an annual basis do break down into student assaults, down to sexual battery, aggravated sexual battery, attempted rape, forcible rape, sexual touching, sexual harassment. So the incidents, the offenses are tracked at a more granular level, and that information is available to look on an annual basis. And then for certain schools, if there are enough incidents, they can be identified as a persistently dangerous school. So, so basically, we look at it both from a prevention perspective as well as what happens when there are incidents.
Okay. Do you have any sense of how many cases in a year, Quinn?
Unfortunately, I don't remember off the top of my head, but that that database is available on the VDOE website, and we can look that up. And you can actually search for down to the region, down to the school, so you can get data, down to that level, in addition to the summary information.
Okay, thank you. Again, don't hesitate to put your questions into the chat, and we'll answer them in just a minute here. We'll get to them. Janice, are you with us, Janice?
Yes, good morning.
Good morning.
Hi, I'm Janice Deakins-Davidson, Executive Director of Children's Advocacy Centers of Virginia. I've been at my role for just coming up on 2 years now, and prior to that, I was Executive Director of a local agency doing child abuse prevention, intervention, and advocacy, including an advocacy center that serves currently serves 10 jurisdictions in Southwest Virginia. So our membership at Children's Advocacy Centers of Virginia is comprised of 19 child advocacy centers across the state, as well as 7 satellite centers of some of those advocacy centers. So my job and my role is to provide training and technical assistance to those advocacy centers. And it is also a membership. We are also a membership organization. So we provide basically a way for members to connect with each other and share information with each other. And as you can imagine, this is a topic we have been grappling with for years now. And some centers, I can say, are doing really interesting and innovative things around this topic. Others are still grappling. And we see probably, and I just ran the numbers on this, and it's really hard for me to say what percentage of the cases, because, one reported 8%, one reported 28%. That's, you're averaging about 18 to 20% a year, but 28% is a significant number of the kids coming through a center. So we've tried to approach it from a, what are you doing kind of thing, but we don't have consistency across the state as to what happens when these children arrive at the doors of an advocacy center. One CEC I'm aware of is doing a great job with dealing with the alleged offenders, and that, like in everywhere, to access services, it's likely you have to charge the child. But in a particular community, the judge has worked out a way to provide services for the child, and if the child completes those services, their charges are dropped. So it's really a nice way to have handled that. Another center I know of is hiring a specific victim advocate for those cases in that center, and that is the center that reports 28% of their cases. So they really have a need to provide that advocacy for both the alleged offender and the child victim. So what I hear from the centers, that's universal, and I would particularly say in the southwest part of the state, so Roanoke South and Southwest, is the lack of access to and availability of appropriate mental health intervention. And even where it exists, it is not adequate to serve the need, nor are children families able to access the services due to financial reasons. So there's a financial component there, that even when there is one or two mental health professionals who deal with the issue, it's not enough to serve the area, nor can the children often access the services due to financial reasons. So it leaves the centers, I think, in a particular quandary, because not all judges are going to handle it the way that center's judges. Not all CECs have the access to have funding to have a specified victim advocate. So how do we universally approach this so that these children are getting adequate services across the state, and that's consistent from Fairfax to Bristol? So that's kind of the quandary we're in as a state.
Okay. And I guess I'm inferring from your comment, Janice, that there are more services, not enough, but more services in other parts of the state, and in some cases they're more affordable.
I'm not sure about affordability as much as how the availability of funding to provide those services.
Okay. All right. Thank you. Okay, Shannon Hartung from the Department of Social Services.
Yeah, thank you. Thanks so much. All right, well, I just wanted to give just a quick reminder in regards to CPS. And so Child Protective Services, they are services designed to assist families who are unable to safely care for their children. And what we do is we identify, we assess, investigate, and then of course, treatment of abused or neglected kids. We receive the reports of child maltreatment, we respond to valid reports of child maltreatment, we facilitate services to the child and their families, and then certainly our goal is to support the family and strengthen the family. Just a quick refresher on what a valid complaint is. We have to have a victim, so the alleged victim, child or children, must be under the age of 18 at the time of the complaint or report. The alleged abuser is the alleged victim's child parent or other caretaker. The local department receiving the complaint or report has to have jurisdiction. And then, of course, we have to have the circumstance described needs to allege child abuse or neglect as defined in code. So rather quickly, how are we addressing child on child now? I get asked this question all the time, and there's really three ways that that DSS is working with these types of referrals. So first, we can accept the referral for a lack of supervision on the caretaker. So that certainly would be when a child has been left in the care of an inadequate caretaker, or in a situation requiring judgment or actions greater than the child's level of maturity. The second way is we can certainly accept the referral for sexual abuse investigation, because if one of the children identified is the alleged abuser or neglector, and he or she is in a caretaker role. So we can do an investigation if the child identified as the alleged abuser or neglector is in a caretaker role. And then the third option would be opening the family as a prevention case for family support. In this type of response, the family would need to agree to services. And then certainly all referrals are referred to the CA office or the local law enforcement, and should include a referral to the local CAC if there is one. And just a quick reminder, we are state run and we're locally administered. So practice could really slightly different from locality to locality. What they do in Spotsylvania County could be completely different of how they handle a referral such as this, maybe out in Carroll County. So just kind of keep that in mind. That makes it a little difficult. Some data I wanted to share. We are really data driven at VDSS. And for fiscal year 2020, we had approximately 75,759 total referrals made to DSS. A little over 35,000 of them were accepted for an investigation or family assessment. Remember, we're a differential response state. And then just a little bit over 40,000 referrals were screened out. So what we did is we looked at those screened out referrals to see one of the reasons that when a locality screens out a referral, they have to mark the reason for screening it out. One of the reasons they can pick is because it's a child-on-child sexual abuse and the alleged abuser or neglector is not a caretaker. So that is a reason for screen out. We looked at those. So we looked at all the referrals. We pulled out those ones that had a reason for child-on-child sexual abuse, alleged abuser, neglector, not a caretaker. And there was 1,535 of those for the entire state. So I thought that might be helpful for you guys. And then we've been asked this question a lot. I just had this conversation with Nicole, I don't know, maybe a month ago. But really, where do we go from here? You know, we know there's a need. We know there's a need to better address these types of referrals. So if you haven't heard, our prevention program has been enhanced and it now includes in-home services. Yay. These services are really what used to be CPS ongoing. They're now called in-home services and they've been enhanced. And they're now part of our prevention program. So they have their own program manager and their own staff to handle these types of cases. And we did this because the services, they aligned with, like I said, our CPS ongoing in our current prevention practices. And it's really a set of practice and policy to support the best practices and outcomes for our children and families. And setting up our practice to support children remaining with their families, right? That's what we're in here for. And in their communities are really the basic tenets of our Family First. And the goal is to provide easily accessible, equitable, and individualized services to reduce the reoccurrence of child maltreatment. And then, you know, we're really looking forward to working on a community response on this issue. It's much needed. We will continue and we look forward to partnering with our CACs, our CSA teams, and our other community partners. And then we are absolutely going to continue to explore on how to enhance our guidance around this issue for an increased prevention response. And that's all I have for now.
Hey, Jenny, can I jump in just 1 second? Folks, it looks like in the chat, I'm the only one that can see your comments. And I'm not sure how to fix that. So I just want you to know that I can see your comments and questions and I am taking note. So don't be alarmed. And I have been trying to fix that, but I think it's probably best if I not do too much more. So anyway, I'm here and I'm listening.
Nicole, I can see Allison just put something in the chat, so I can see her response, just an FYI.
Okay, I'm back. I'm sorry.
Okay, so yeah, in the chat, hopefully everybody has an option where you can say to, and you can click on everybody. I'm hearing feedback that some folks aren't able to do that. So anyway, sorry to jump in.
Okay, are you done, Chen? I'm sorry, I lost my internet connection for a second there. My apologies.
Yes, I
Okay.
am done. Thank you, Jenny.
Lisa. Hello,
Okay,
Lisa.
great. Hi, thank you. My name is Lisa Wright. I work for Greater Richmond SCAN at the Child Advocacy Center, and I'm an LCSW. I oversee our outpatient treatment services here at the Richmond Child Advocacy Center, and we see primarily kids ages 4 and up who present with either experiencing sexual abuse, severe physical abuse, or exposure to violence. And I started my career 28 years ago as a clinical social worker and worked with youth with problem sexual behavior and adult offenders. And I became a certified sex offender treatment provider at that time. But I have been at the Richmond CAC for almost 17 years now, which is really great. And I really believe very strongly that all children, so all children, youth with problem sexual behavior deserve access to really quality treatment and really should be assessed and have access, just to be able to heal from what they've been through. And in my experience, most kids that I've worked with really will disclose their own history of sexual abuse and or exposure to sexual material or maybe sexual behavior. So that's usually typically in the background of the ones who are acting out sexually. And in preparation for today, I actually reached out to my colleagues, so my coworkers here at the CAC in Richmond, and also to mental health providers across the state in Virginia. And I heard back from several folks. I just wanted to, I'm combining their feedback and my perspective as I'm sharing with all of you. And I'm going to be referencing my notes as I'm going through to make sure that I hit on all the points that people have shared. And it seems to be pretty common across the state. So all of us who convene where there are mental health providers within child advocacy centers, we're definitely experiencing the same thing, as it pertains to these cases where it's child-on-child sexual abuse. So I'm going to start with effective strategies. I'll start on the positive and then I'll lead into the challenges that we've experienced. I think that the first effective strategy that we've had is really just to identify that there are needs and look at what the needs are and needs for treatment and assessment for children and youth with problem sexual behavior, and to identify those needs across disciplines. So at child advocacy centers, we're in a really unique position where we have the opportunity to work with multidisciplinary teams in a really nice way. So just being able to share, what those needs might be for the kids who present. And also, we're really being very careful to use the terminology of problem sexual behavior instead of offender or alleged offender, but it's sort of in process. And I think we're referring to them as alleged offenders sometimes, and then youth with problem sexual behaviors, hopefully moving forward. I think we definitely have seen that effective strategies is that when there's a system response to work towards determining victimization. So oftentimes we have partners, investigative partners who will refer kids to our child advocacy center, and they will ask that both kids, so that the child identified as the victim coming in, and then also the one identified as the one with a problematic behavior, to be interviewed just to see if there's victimization history in the past, and almost maybe conducting another investigation if there is, history for the child with problem sexual behavior. And like Janice had mentioned, there are some jurisdictions that are really moving forward with criminal charges just to make sure that there's funding and accountability so that those kids do have access to treatment. And I love the idea I heard of the one jurisdiction where if the kids really do follow through with all the recommendations, then the charges are expunged. So, it really gives them incentive just to hang in there and do everything that they need to do. We also believe that it's really critical with cases involving siblings that professionals and professional treatment providers collaborate together so that there's really good communication, making sure that both treatment providers understand what's happening for the child with problem sexual behavior, the child who's experienced the victimization, and making sure that everything is able to be processed, especially prior to a reunification process, if and when that happens. And ideally, it would happen in conjunction with the two therapists, making sure that both kids are ready to be able to do that work and that the parents are ready. Team collaboration has been really important. So including guardian ad litem, legal team, DSS, whoever is involved with these cases, just to make sure that we're all, in really good contact and communication with one another. Also the use of really good treatment models and also assessment measures. So we use the trauma symptom checklist for children, trauma symptom checklist for young children, and the child sexual behavior inventory that are really meant to look at problem sexual behaviors and, help to influence the treatment needs and the treatment recommendations. There's also trauma-focused cognitive behavioral therapy for problem sexual behavior, and the Boundary Project, which is a curriculum that was developed by the Gill Institute in Fairfax County that we have found to be very effective and helpful. We do have psychoeducation materials. So the NCTSN, or the National Child Traumatic Stress Network, has really great handouts that we give to all caregivers who come through when it's a child sexual abuse case that are about normal development, so normal sexual development in children, so that parents understand what that is, and also around problem sexual behavior. So even for those who've been victimized, just to make sure that the caregivers understand and keep a lookout, if any of these things present for their children. We're also advocates of strong support for caregivers. This is a lot to manage, particularly if it's in their family and it's their children, both children. We definitely need more trained providers. I would say that's across the board, across the state. And I learned that one CEC is partnering with a local university close to them and the Department of Health for more training on problem sexual behavior. So this is going to lead me to the challenges that I have. So the limited treatment providers, especially those for families who have limited resources. So if the families don't have insurance, if they have transportation barriers, just access to treatment providers is a really tough thing anyway. And for those that are limited, because there's not many people who are trained to work with kids with problem sexual behavior, that just makes it even more challenging. There are a lot of difficulties with collaboration amongst providers. I think for private providers, their schedules tend to be really tight. You can't bill for the time, most of the time, for collaboration. So, it's just a hard thing to get people on the phone or in a meeting in person when and if we get to do that again, right? And then there's often kids are separated from one another. So when it's siblings, so child-on-child sibling cases, and caregivers may be separated from their child. There's a lot of experiencing of grief and loss, a lot of feelings of guilt and shame. So I'd say that's across the board for all family members. And oftentimes the grief processing really presents as the most pressing challenge when they're coming into treatment. So, just trying to work that through with everybody. The response from the caregivers is also, many are feeling very overwhelmed, like I mentioned before, and also torn between supporting both kids and also oftentimes really blaming themselves. Why didn't they see this happening, or why weren't they there to protect them, that sort of thing. There is limited support for caregivers, kids with problem sexual behavior. So in terms of even treatment providers or support groups or psychoeducation, there's really not across the state, there's not a lot of opportunity. Some caregivers also worry about safety. So, and I'm speaking more for the caregivers of the victim, the ones identified as the victim children. When the youth with problem sexual behavior is not prosecuted or held accountable in that sort of a way, they really worry for the safety of other children, thinking that child is going to act on other kids, which makes sense. There are also a lot of cultural worries, such as keeping family secrets, stigma around mental health, distrust of the system, that sometimes are barriers and get in the way of families accessing services. And it also does seem like there's many of the parents of the kids with problem sexual behavior that don't follow through with accessing services, and for a variety of reasons. I think a lot of it is that they're not easy to find, really. And I do think there's an opportunity here for us to identify early, when we're seeing these kids presenting with problem sexual behavior, to assess them and get them into treatment. And I feel really hopeful with the treatment that I've seen personally, that I've been involved with, and also the staff here, in using the curriculum that we have because we do see kids processing what they've been through, learning, strategies and really healthy relationship skills, skills on healthy boundaries. And we've seen them just, have changes and have more healthy and safe relationships. And I did look very quickly, and sorry, I'm going way over my 3 minutes, but the statistics for our center for kids who have come through in the last 2 fiscal years, so 1920, the kids that are identified, and we have them in our system identified as alleged offenders. So it's children who perpetrated sexual abuse. In 1920, we saw 113 kids, and that's at the Richmond and Henrico Child Advocacy Centers. And so far in fiscal year 20, we've seen 79 kids. So the ones who are identified as, the offending children. So that's all I got.
That's a lot. Thank you so much for kind of polling folks and bringing that information to us. That's wonderful. I want to just spend a few minutes before we go into questions, sharing some information that, so Nicole had some discussions with law enforcement folks, Nancy Oglesby and Judge Ellen White from Campbell County, who is a member of the Child Abuse and Neglect Advisory Committee, and just a couple considerations of what's going on in terms of law enforcement and the judiciary to add a little more complexity to the picture that we're painting here. There was a recent change, and I'm sorry, I'm going to use notes too because they're some of the it's a little complex. There was a recent change in statute that made putting children convicted of in these cases on the sex offender registry discretionary in cases that were kept in the juvenile court. And in general, judges tend to go with the recommendation of the prosecutors in this case. So the discretionary kind of questionable. Also, the comment that prosecutors' ability and skills in these areas varies a great deal. Sometimes, this is very similar, the dynamic as you have with domestic violence cases, new prosecutors are put into these cases, and the cases are extremely complex, and they are, the comment was, new prosecutors like to lock everyone up, and so it's a kind of a narrow approach essentially to prosecution. Judge White noted that there are 2 opportunities every year to train judges, and she has not received any training on these cases. So there's a judge training issue there. Nancy mentioned that the CHINS process, Children in Need of Services, is a really good and appropriate way to handle these cases in the courts. And not all juvenile courts will allow or accept these CHINS petitions. So that's another kind of area for us to take a look at. A couple of years ago, another law passed where misdemeanor crimes committed by students on school grounds where the reporting of them became optional. And before that, principals were required to report them. Now, this was part of a larger effort to alleviate the school to prison pipeline. You can see the ramifications it might have for these cases if these are not reported. There may be some undercounting. And then under Title IX, a reminder that folks have a right to sue schools that receive federal funding for sex discrimination when there is a failure to act on these cases. And with the Office of Civil Rights that's now been established in Virginia, it might be that we would see more of these cases being challenged and maybe take a more active role in making these cases work. So I think we will return to the law enforcement piece at a later date, Nicole, is that correct? But wanted to just mention those here.
And I wonder if Sandra has any comments or kind of perspective on any of those issues that you outlined.
Yeah, good.
Sure. We do a lot of chins petitions on a lot of the child-on-child, depending on the age. We do not do a lot of criminal, or actually in my career, I think I've only charged one, maybe 10-year-old due to a violent situation. Usually they're all chins if they're under 12. 12 and older, just depends on the severity, the lack of cooperation with parents, or just to see what kind of services the child is in need. It's more about the service aspect of the children, not about the, of course, we are here to keep other children safe. If we see that the children needs to be detained, we do take the charge route. However, we really lean on the chins petitions a lot more so in our jurisdiction, just for the service base for that. If the parents don't cooperate, or we see that there's a more of a need for that. However, our CAC does respond very well to child-on-child, especially when the children are under the age of 12 or 10. They do provide great services, and part of our multidisciplinary team, we also have the school staff on our team, which is wonderful because they see these children every single day. They know them more than myself or DSS, who sees the children for 15 minutes, 30 minutes, an hour. So we really rely a lot on our social workers within our school system, and that makes a great outcome for most of our children here. Being in a rural community, we just try to use all the services we can get.
So, Sandra, it sounds like you have kind of exactly what Lisa was talking about, a really strong collaboration on these cases. The chins petitions, the services, the school board, you've at least got the potential for working.
Yes, ma'am. And our surrounding jurisdictions, we work a lot with Patrick, Henry, Bedford. They're probably more so as far as the need for services. The Roanoke Valley area, they do have more services than we do when you come more south for a Pennsylvania County. We work a lot with them, and they have really responded well with the aspect that we have the school on board that does help a lot with the social workers. And our judges here respond very well to the chins petitions with these types of cases. And we don't take them all to chins. It just depends on the severity and if we're getting the cooperation we think we need for family services. But our juvenile intake system, they allow me to file chins at any point. Any of the law enforcement here, they're very receptive to us coming in to file any type of chins versus a criminal charge.
Okay, thank you. If I could address some questions to the clinical folks in the group, I'm wondering if you have any information about how these cases are being affected by the pandemic. Lisa, you mentioned, I'm not sure the year is done, 2021, right? You had 113 in 2019, 2020, and now you have 79 so far. But how is the pandemic affecting this work?
I think it's sort of yet to come, especially for us around here in Richmond, because the kids are still in school virtually. So I think there's just not as much access for kids to tell about what's happening. And unfortunately, I do think that they're less supervised because parents are having to work and they're at home. And then kids having more access to online everything. So probably that exposure to inappropriate, material or sexual abuse material is going to be higher. I'm expecting that we'll have an increase, but so far we haven't seen it yet.
Okay. And then Art or Janice or Lisa, how effective is the treatment for children who commit these acts from preventing future abuse? What is your experience? What does the literature say about it, the science of it?
Okay, that's a large question. Trying to
Mhm.
answer this politically correct as I can. So we have our data. You can actually, if you go to the DJJ website, there's a resource link, and then there's something called the Data Resource Guide, or the DRG, which
Okay.
has all kinds of statistics for the entire department. But in a nutshell, we measure recidivism in three areas. There's rearrest, reconviction, and then there's reincarceration. And so depending on how you compare apples to apples or apples to oranges, but for the most part, kids that are committed to the department with inappropriate sexual behavior charges that are in that ballpark, generally their stats for reoffending are about 20 points less than the overall population. The overall population, the statistics are not all that great. They're always about, they seem to be hovering that upper 40s to almost 50%, depending on how you measure it, whether it's a 12-month or there's also a 3-year. But generally, what we find is that youth that are committed tend to have less conduct disorder behaviors, but they have a lot more social skill deficit. And so they tend to do a little bit better because they don't have the extensive non-sexual offending behavior that might toss them back into the system again. So that's a bright spot for that population. Not so great for the kids that are not committed on inappropriate sexual behavior. But that's the short answer to a larger, complicated data picture.
Anything from Janice or Lisa on that?
I'm going to leave that to the mental health professionals.
I didn't look up the research, which I certainly can and send your way. But I think just of what we've seen, and I'll really speak to our treatment providers here, is when there has been problem sexual behavior that presents, when it's treated, and when the caregivers are really involved. So when there's a lot of support around to make sure that there's safety and to follow through on treatment recommendations, that it's been very successful from what we've seen. And we haven't seen them come back around, as identified as offenders. And we actually have an open door policy. So if they are struggling with something as they get older, so typically when they're getting into more relationships or things like that, they're able to come back for treatment services with us. So far, so good. And it is really individualized. I mean, the treatment needs to be really specialized for that kid, for that family, following curriculum, following the evidence-based information that's out there, but really making sure that we pay attention to, what the specific needs are for that kid.
Okay, so Gwen, I have a question for you about the Department of Education. I'm wondering if there's any specific guidance or training for school administrators, principals, teachers relating to identifying and reporting these cases.
Well, so I think it sort of depends on which aspect of this issue we're looking at. So for example, there's definitely requirements for training of staff relating to bullying and harassment, which would include sexual harassment. And then of course the schools have to comply with Title IX in terms of reporting and investigating sexual assaults. And then, as I mentioned, there's also requirements for training around human trafficking. So I think there's, there isn't training that is specifically related to just child-on-child sexual assaults, but it comes from different ways of looking at it. So whether, it's sexual harassment or human trafficking, or even abuse and neglect reporting, right? So all school personnel are mandated reporters, And part of their relicensure requires them to complete recognizing and reporting child abuse and neglect training. That's part of their relicensure.
Mhm.
Can I jump in? I just wanted to correct one thing I said about our recidivism rates, just to make sure I wasn't misunderstood. So when I said that the kids that come into the system that recidivate at 20 points less than the overall population, what I neglected to say, that is for any offense. So if you come into the system and you have an offense, or you're adjudicated on a sexual offense, and you go through the treatment program, and so you commit another offense, generally what we find is that it's not a sexual offense. The overall recidivism rates for the population of kids that we treat, we've had since the programs have started, we've treated over 1,600 kids since the early 90s. It's like 2 to 3%. The national rate it's a little bit larger than that, but for the most part, I agree with Lisa. For the most part, kids that are invested in the treatment programs, the recidivism rates for sexual assault for kids is a lot lower. It's very low as compared to the adult sector. So I think there's a real bright spot in that treatment range in the field. So I just wanted to make sure that I wasn't misunderstood there. So anyway, sorry for that.
And why do you think that is? Is that kind of a developmental issue for children at that particular moment, that just kind of perfectly goes with the treatment structure?
But I could just tell you, I mean, based on anecdotally from what I've seen, and I work in the deep end, so by the time kids are committed to DJJ, their behavior was so egregious that it couldn't be treated in the community, or they're high risk or moderately to high, or they've been tried in outpatient and that didn't work, or they were placed in another residential facility and that didn't work. And so the department has taken great pains over the last several years to transform itself to decrease its intakes and put more money in the community so that we wouldn't get them. Only as a last resort. And I think what happens is that when it comes to sexual offenses and inappropriate sexual behavior, there are still a lot of CSUs and judges in politics where people are afraid and they don't necessarily know how to deal with a lot of youth in the community. And so you get a lot of kids who are committed, and they don't have the same level of conduct disorder behaviors as other kids who get committed. And so what they really need is they need a lot of help in social skills, that kind of an area. And so they tend to do better, I think, overall, as compared to kids that have a lot more violent offenses, or kids that have a lot more ingrained conduct disorder behaviors, that have done more harmful things, and so they're deeper into the system. That's just kind of how I see it.
Mm-hmm. Thank you. And one last question for Shannon, then we'll turn this over to Nicole for the chat. Shannon, can you, do you know if there's any particular jurisdiction in the state that you would highlight as having a strong response to addressing these cases? Is there anybody that's got sort of a great practice besides Franklin County, it sounds like?
Yeah, no, Jenny, I don't know that off the top of my head. I can certainly, we have practice consultants in each region, CPS practice consultants. I can certainly reach out to them. That is not a question I've posed to them as to who is doing this well out there. I'm not sure. I mean, certainly they're all working these types of cases, but I haven't gotten any feedback in regards to who's doing this very well. But I can certainly check and see what comes back. I think that'd be a great idea.
Yeah. Okay, thank you. So I've seen some stuff coming across the chat. Nicole, are we ready for a little chatting? Questions from the chat?
Yeah, I hope that everybody can see the chat. I still am not clear on that, but I can see the chat, so I will be your spokesperson. So Jennifer posed a really good question. She works in Washington, D.C. and the social services there, and she was saying that they're redoing their mandated reporter training. And her question is, first of all, are mandated reporters required to have any kind of training? And if so, how often are they required to have that? Which I never even knew that there were states that had mandatory training for mandated reporters. So, Shanna?
Oh, wait, are you asking me? I'm sorry.
Yeah, I think that you probably know the most about this.
Yeah. So, I mean, certainly we do training for mandated reporters. We have that online. Quinn mentioned that earlier for our educators and for non-educators. I do not know the rules for each specific, field for mandated reporters in regards to when they have to complete it or when they don't. Quinn can certainly speak to the educators, and I think Shorty did that, but I don't know specifically for each field.
But just to clarify, there's no state statute that says that if you're a mandated reporter, you have to take this training from this entity once every 5 years or something. There's nothing like that.
For educators, there are.
Okay, so within various professions, and I would even imagine like if you're in a hospital system, the hospital system is going to have there are specific policies related to it, but not state level, laws related to it. Is that correct?
So other than for educators, part of the legislation that was passed was for first-time licensure for educators, as well as for relicensure, they are required to complete mandated reporter training.
And what is the frequency of relicensing, Quinn? Is that like every 10 years or something?
Yes, it used to be 5 years, but it was expanded to 10 years.
Okay, all right.
And we recently just updated the guidelines for the curriculum for mandated reporter training for educators.
Okay, great. And then we have a couple of questions from Linda. And I think some of these issues were touched on, but you all might want to expand on it. And Lisa was very kind and actually entered her answers in the chat. So the first is, are these children presenting with other behavioral issues? And then what, if any, services are offered to parents? And it sounds like, yes, they are generally presenting with other issues. Is that correct, Art?
Yeah.
Lisa?
Were you asking me or anybody?
Sure, we can start with you, Art.
So the answer is yes. So we usually see, I mean, we have kids that present with depression, anxiety, ADHD, substance use disorders, aggression management issues. I mean, you name. We have some kids that are on antipsychotic medication. We have the whole range. You have some kids that come in on the spectrum. We do offer family therapy, but we're not nearly as capable of doing that as outpatient centers. We just, it's not as family friendly. It's just by virtue of our architecture alone, and security, and COVID has just killed us. We've had to, our visitation has been horrible with COVID. We've had to adapt to that. And so for the most part, once kids are adjudicated, family therapy is not nearly as helpful as it is in outpatient, just because of the territory. So we offer it. It's just hard getting families, and some families struggle with transportation. And the department has done better trying to help families come in with transportation, but it's still just by the nature of distance. CPPs have helped a lot when we get kids placed in local detention centers that are closer to their home, but by virtue of geography, that has been a challenge.
And so the telehealth or telemed or those sort of mechanisms have not sort of been transplanted into the. Well,
so, I mean, we have that for treatment team, and we can do it. It's just not the same as being face to face, but we have had some of that. It's just not nearly as I mean, treatment team always has, the parents have the option to call in. And so they're usually pretty compliant with that if they want to be there. But family sessions, if not, I mean, we wouldn't recommend like a reunification session, like on the phone or on screen. It just wouldn't be safe.
Mhm.
And it can Lisa, maybe can you speak to the issue of services offered for parents to the live, kind of how important that is, and maybe Janice as well as kind of the, like, that seems to be an identified need.
Yeah, sure. And I would say too, for the question was specific to the behavior. I think what she was asking, behavioral health issues. Sorry. Okay. So I would agree 100% with what Art said about the kids who present with problem sexual behavior have the similar symptoms to kids who are presenting as victims. It's oftentimes symptoms of PTSD. So similar things with hypervigilance, anxiety, depression, and then definitely struggling with some behaviors. And also, I mean, it's internalizing in behavioral, like acting out sort of things. And for caregivers, there really just doesn't seem to be a lot of people where that's their training or expertise to work with caregivers. And many times when caregivers come here for forensic interviews, they're sharing their personal history and their own victimization history for the very first time ever. So then the need arises, you know, there's a lot of, I think, triggers for them, need for additional support just to process their own experience, in addition to supporting their children. And they're just limited. I think many parents will prioritize treatment for their kids way over themselves. You know, they'll come here and seek the treatment and be very invested. And then when it comes to getting help for themselves, I think they put themselves on the back burner, which is true for, you know, a lot of caregivers, I would say. And the need for support groups. Sometimes parents really enjoy that, like to talk and hear from other, you know, caregivers what they've gone through. And some not so much. I mean, I think they just don't really want to, they can barely manage what they're going through and don't really want to hear what other people are saying. So I think there really needs to be a variety of options for individual, family, and group treatment for caregivers as well.
And following up on that, Lisa, so if you have parents and caregivers who are triggered, do you then refer them to others? Are there services for them if they want services?
You know, I think it's kind of the same issue. I mean, I think there's private providers. So if there are barriers to access those services, and we try, you know, if we have availability, we will provide individual therapy for caregivers. But honestly, like we can't, you know, we're having a hard time meeting the needs of all the kids that need the help that's out there too. So as is everybody else. But I think it's limited. I think for both kids and for parents, it's limited what's out there.
And may I jump in? Because I'd like to echo all of that. As Lisa said, that's universal in Virginia. I mean, probably in the country right now, and it's particularly difficult. It's difficult everywhere, urban and rural settings. But in rural settings, it's a bigger problem because there's lack of providers. But also, I've seen a couple of CCs do an amazing job with telehealth through this whole COVID crisis. And families have participated more on average than they did before because there's not a transportation barrier. And so some of the CCs in the state are going to continue to use telehealth even past the necessity of COVID to do so. So I think what that says is if families have access, they participate better. So we kind of have to factor that into transportation, particularly can be a problem, as can childcare for other children, those kinds of things for parents. So if we can get them to a place where they don't have those barriers, then I think we'll do a better job by them.
It almost seems like just that there are so many needs for these families that one of them is almost like it's like a case management support service for logistical I mean, I'm thinking of even like housing. If you have multiple children living in a 2-bedroom apartment or something, and how are you supposed to keep how are you supposed to keep everybody safe just logistically? There's like so many kind of social factors that can touch on these issues. So yeah. So a couple of other questions. I have a question actually about the kind of the information. It seems like, when you look at the state police data on this, you can actually get some pretty good breakdowns just on ages of victims and perpetrators. I wonder, does CAC, do you guys have that? Is there a way to uniformly kind of categorize these cases based on kind of pre-adolescent on pre-adolescent versus like adolescent on pre-adolescent? Like, because to me, and I'm not a clinician obviously, but that seems like it would be relevant as far as like specific strategies for treatment, but also prevention, and kind of what the potential protocol or guidance could be on these cases. Does that exist in the CAC world, kind of profiles?
We have data. Janice, you can answer this better than I can, and I'm not sure if it's just set up for how we have it set up, but we have the kids listed, at least the ones again identified as offenders, either under the age of 13 or between 13 and 17. And I'm sure there's a way to compare the age of the victims or whoever is on the case with those kids. But it's on our CAC database, so I think easy to do across the state if it's not already like that.
And the database that most CACs use is the A-Track. And certainly if we can't pull it now, we have access to somebody who can help us develop a report to do that. So that would be a good piece of information to have.
And I think from a school perspective, if these incidents are taking place at school and they're being captured as conduct incidents, the data is reported at a school level, so you can break down the data based on elementary school, middle school, or high school.
So a follow-up question for you, Gwen. You were in talking about the data, you I think said something about like a category of dangerous schools. Can you speak to what that is? Because that doesn't sound good at all.
So when schools report in data around disciplinary incidents at their school, depending on what the offenses are, they are given sort of like, I guess, points. And if you have enough incidents that are dangerous, and there's, and that's defined in the information, the school can be classified as a persistently dangerous school.
Has there ever been any discussion that you're aware of how that might potentially be harmful and kind of getting schools to address these issues? Like how, that's not exactly an incentive to categorize these cases and provide a response that's appropriate if you're going to get, that's the whole thing with this issue is you want to be transparent in it, but you also don't want to discourage people from acting on it. Is there any discussion at DOE about that you're aware of? You may not be aware.
You mean in terms of how to make sure that schools are reporting what they should be reporting?
Yeah, and that they're not, it's that to me, and maybe it's just kind of my experience, but that if you're going to start, categorize, it's the same thing with universities and sexual assault. It was with the Title IX stuff, that schools, people would look at their rates of sexual assault and you would categorize universities as having, a date rape campus or something, which is really horrible messaging. And it discouraged universities from reporting and addressing these issues. Because the last thing you want to do is be classified as a dangerous university or a dangerous school. If I'm a principal in a struggling school system, I don't want my school classified as a dangerous school. I'm going to be dissuaded from addressing these issues formally, which doesn't seem to be helpful to the actual issue.
So I think from VDOE's perspective, we collect a lot of data across the board. So, obviously this is not the only data that we collect, but there's also like school climate surveys that, are completed on an annual basis. So, we really are trying to take a look, across a lot of different data just to get a sense of the climate of the schools from, not only a positive climate, but also like a safety issue, right? And then the other thing is that the last couple of years, we have really shifted and updated our student conduct guidelines to make it more of a positive intervention and support perspective rather than punitive. And really starting to collect a lot more information relating to what kind of responses, administrative responses are being taken based on student conducts. So really trying to shift that and emphasize more on supports and interventions.
And do you know, Quinn, how has the role of school resource officers fit into this picture, and has it changed over time to get more towards this prevention, standards of conduct?
Mm-hmm. I think that still is at the local level. I do hear, some localities are looking at the role that SROs are playing in their school, but that is not something that we at VDOE are, from a guidance perspective, we have not addressed that, but it has been more, the way we address is more around how to respond to student behaviors. Really providing a lot more guidance in terms of how to, again, as I mentioned, provide these supports and interventions that are not punitive. So, things like restorative justice or, getting supports from student support personnel like school psychologists, school social workers, and school counselors. So really, there's been a lot more emphasis on that, and all of our trainings have really been geared towards that positive support and how to provide more of that to students.
Mm-hmm. Okay. And that's from the principals down to the teachers. You're talking about that training is available?
Yes. Yeah. Yes. Mm-hmm.
Okay.
And just to this is sort of related to it, and but not directly, is that we did get passed through legislation changes to our standard of quality. So, for example, the ratio for students to counselors have been reduced, and this coming year it will go down to 325 students per counselor. And then I think we're waiting for governor approval right now, but another standard quality that's been approved is 1,000 to 3 student support personnel, and student support personnel would be psychologists, counselors, school nurses, or other licensed behavioral and mental health professionals.
That doesn't sound like a very, that doesn't sound like a great ratio, but that's an improvement you're telling us, right?
Yes, that's a huge
Okay.
improvement.
I mean, that 3 to 1,000 just doesn't strike me as wow when you're talking about kids.
Yeah, and I know that, and I think Amy Stride has gotten off, but Voices for Virginia's Children has actually been one of their big priority areas and advocacy is to try and support measures to fund those positions, because Virginia really is pretty low nationally on the totem pole as far as those ratios go. And I agree with you, Jenny. I think it's funny when they're like, "Yay, 3 to 1,000." Particularly with these cases, and we know all the complexities of all of this. I mean, we put a lot on our schools. There's no doubt about it. And you may not know this off the top of your head, and I don't want to ambush you, Quinn, more, but with regard to the family life education, I know that that's an option in Virginia. It's not a required curriculum. Is that correct?
Well, parents can opt their children out of it. Yes.
But school systems also not include it?
Oh, no. Schools, all schools provide FLE, but it's just that parents have the option to opt their child out of it.
Okay, and then, so if they have, because I'm not up on the latest statutes, it used to be that school systems could not include family life at all. There were schools that did not have to offer that, and that they could then, if they wanted to have it, they could choose the components of it that they wished to implement. Is that no longer the case?
So we do have, VDOE has defined learning standards for each grade level for FLE. So it should be consistent across the state in terms of what information is being covered. So as I mentioned before, let me just kind of pull it up real quick. So for example, starting in 4th grade, one of the learning standards is that students will describe the factors surrounding child abuse and child neglect, including sexual abuse and electronic harassment. So, so these standards are defined on a per grade level.
Well, that's a great improvement. That's great.
Yeah. Are there any other questions?
I don't have any others. I have some good comments in the chat. And I want to just in 1 second, just call out and thank Sergeant Sandy again for her last minute participation in this, and for sharing the information she did around Franklin County. So
yeah.
You're welcome. And to the school resource officers, I know in our community, if they have a sexual assault on campus, normally they call an investigator in, just because we like to keep the school resource officer in the most positive role that we can. And sometimes with the investigation process, it doesn't end up that way. So we try hard for our school resource officers and even our road officers that go in and out of the school system to more or less be the reporting agency. And then as long as the investigators, we go in. Of course, we have the more specialties on the interviewing aspect of it and how to interview the children or work to get more services for the children. So just in our community alone, we try to keep our school resources more the positive role. And also the school system. A lot of times if they offend at school, we try to take the school system out of the environment where we've got to be the bad guy, to just keep that positive role for the children of where they go every day and who they see every day. So
Right.
we're big supporters here with our school system.
Yeah, that's great. Sounds like a very thoughtful process. Yeah. Okay. So I think we need to wrap up here. I do want to just call out my co-chair of the Child Abuse and Neglect Advisory Committee, Janine Harper, who is on the call. So hello, Janine. Thanks for being here.
Thank you.
So we want to just reiterate, I mean, I really learned a lot about the complexity got a little bit deeper. The needs and the stresses, very, very complex. And so really appreciate your time and the information that you brought in front of this group. As we said, we are just starting with this. And so there'll be other dimensions and maybe other conversations to be had about what the needs are going forward and what's possible for Virginia to develop. I think we're very excited on the fact board to see something happen in Virginia, for something to come out of this. So our next step as a committee is to pull together a small work group to expand on some of the stuff that we've covered today. There may be an opportunity to develop guidance, a more detailed and formal document that includes some state level recommendations for change. And the fact and other advocacy agencies could then use that information to encourage and try to get recommendations implemented. Okay, so that's kind of where we're headed. We want to, as John Lewis said, we want to make some good trouble here. That's what we want to do. We want to keep the work group small, but if you know of folks who are very interested and could be a great resource, please do be in touch with Nicole, and she will work with you to coordinate and schedule. So thank you again. Do you have anything else you want to add, either Janine or Nicole? No.
Just thank you to the panel and to everybody for,
Yes, thank you.
for participating and for your time and support on all this. I really appreciate it.
And thanks for the work that you do every single day in making this happen. Thank you so much. All right, I think we're done. Thank you. Goodbye.
Thanks, everybody.
Bye-bye.
Awesome.
Thank
Bye.
you.